Hi, everybody. Everybody had a great, satisfying day today. I know I did. So anyway, this topic, pick a path, we've been talking about this as it relates to full arch for probably 15 to 17 years. And it's one of those topics that um, I think it really comes down to the philosophy of treatment planning, really. And those of you may already know, I'm a prosthodontist. I've spent the last 30 years or so really focused on full arch implant restoration. So I definitely have seen a lot over the last 30 years. And in particular, I've seen the natural dentition age out over 30 years, and I've seen the implant cases we've done age out over 30 years. So sort of a unique perspective. I've done a lot of training as it relates to full arch. And I can kind of remember back to the early days of training, maybe let's say 15 to 17 years ago, when we started to do hybrid training. And we would do a 2-day or a 3-day course. And the first 2 or 3 hours was almost like a defense of our treatment planning path, which is full arch. At the time, we were doing something that not a lot of people were doing. And we got a lot of pushback. By usually the first break on that first day, people settled down and they said, oh, okay, I never really thought of it that way. And by the time they got to lunch on the first day, they said, oh my God, this is mind blowing. I've never thought of things like this before. That reaction, that gut reaction that doctors had in those earlier days of full arch training has kind of subsided. Now we do the training and people generally doctors seem to be prepared for this idea of the concept of trading teeth for dental implants. But I think that there's still philosophically, from a treatment planning standpoint, there's still a lot that still has to be answered. So again, I really think that this is really an interesting topic, and hopefully I'll get you thinking about some things. And where you are in your practice and where you are in your career might not put you in the same place looking through the same set of eyes that I do when I look at these cases, and that's fine. I mean, I could even tell you that 5 years ago, I was thinking differently than I am today. And probably in 5 more years, I'll probably be thinking differently than I am even right now. So it's definitely a transitional thing, the way we look at our cases. I've got to tell you that as the founder and CEO of Highbridge Full Arch, I do have to disclose that, and this really has been my training and my research and development as it relates to full arch, as well as being in practice, in my own practice, has really sort of been, I think, a blessing over the last 30 years. So I wanted to disclose that and sort of kind of get you to think about this responsibility that we all have when we're evaluating a patient, and we'll call it a comprehensive treatment plan, where we're looking at either the full jaw or the full arch or the full mouth, not what I would typically call a segmental restoration. We really have to actually take it seriously, personal responsibility for guiding a patient in one direction or the other. Let's face it, we have the ability to really impact somebody, and oftentimes how we propose something to a patient is going to really sort of dictate what they choose typically. And I think being very transparent about the fact that there is a choice to be made, and that we're going to help educate you on what your status is today, and help you decide for you what's the best option. Do you want to go and keep your teeth and let's fix those teeth and restore those teeth and commit to them, or do you want to replace those teeth. And what you'll see I think I have 5 cases that I'm going to show you tonight. That in a lot of these cases, you could really go both ways, and oftentimes it's going to be the patient that will dictate the path that we choose. I did an article a couple years ago in actually Dental Economics called "The Treatment Planning Dilemma," and this really is the kind of the pick a path thing. And I don't know if you can see the lower right, but as we look at prognosis on the left, poor, fair, good, and excellent, and you look at time as you go to the right, what I have found over time is that full arch treatment in my practice tends to have seemingly a better long-term prognosis over long periods of time than restoring. And I've done a lot of very heroic dentistry over the years on natural dentition. So I definitely feel like I have like I said, an interesting perspective. One of the things I want you to think about is, from a patient's perspective, is how long should a dental solution last? We know there's no lifetime warranties, but you do have to be aware that our patients, whether right or wrong, have an expectation as to how long the treatment that you're going to recommend is going to last. And at some point, you'll realize, as you're into practice for 10 years and 20 years and 30 years, that you may have made some promises over the years that didn't quite go the way you predicted. And at the end of the day, it's not all on the patient. So although we're having patients choose a path, understand that if you pick a path for a patient or help them pick a path for a patient, and that treatment comes up short of expectation relative to how long it should last, understand that it's on the dental practice almost as much as it is on the patient. So the responsibility is bigger sometimes than you think it is, because it could become a liability in your practice if the perceived warranty isn't held up. So our learning objectives today are going to be that, as we look at our patients as people, really what we want to do is we want to understand what their chief complaints or their chief concerns are, and what their goals in their treatment are. I think I can't stress enough how important it is to spend the time with a patient, digging into their mindset so that you can understand where they're at when you meet them for the first time. I think also, once you've done that, I think recognizing the risk factors for that patient and evaluating their current status dentally will also be important, so that you can decide whether or not the teeth that they have can make it for the long haul. Use prognosis-based treatment planning to evaluate x-rays and determine the best treatment options. I'll use that term prognosis-based treatment planning actually quite a bit, because I think not only do you need to really get into the patient's mind, but you got to get into the patient's prognosis, their teeth, and you have to create a prediction as to what's going to happen in the future if you're really going to do good treatment plan. And then our job, of course, is to help them with their decision when there isn't a clear path. I saw a case today, coincidentally, that I just put it up there for the patient to look at, and we looked at each other and go, okay, we're not going to talk about anything besides how are we going to replace these teeth. There was no debate. The patient knew that their teeth were, 20 years beyond hopeless. So again, the decision is important. What to consider when looking at these solutions. Let's see. So we talked about the expectation of longevity. I think cost is going to be a very big driver for most patients. Comparing cost of looking at various solutions. You got option 1, 2, and 3, and the cost is, small, medium, and large, as we say. The expectations in options 1, 2, and 3 are, fair, good, and excellent. This is the stuff that you're going to have to do when you're trying to pick a path. How long does it take from start to finish? I think patients care. They also care, believe it or not, how many steps are there? How many months are there? These are all things that I think when we look at the options that are available to any patient is important in their calculus of what they're going to do. And of course, we go back to risk factors as really being, prognosis-based. So, when we look at somebody like this and we look at, what, with any patient, I'm oftentimes asking the same questions over and over again. Actually, we just developed a survey that our patients are taking, which tries to predict risk factors. But some of the things in our survey are, genetic predisposition. One of the questions we ask is, did either of your parents wear dentures? Have you ever been diagnosed with periodontal disease? Genetic predisposition is definitely a thing. Their daily habits obviously are also a thing relative to risk. Why do patients lose teeth? They lose them because of periodontal disease. They lose them because of occlusal disease. They lose them because of decay, and decay can be, the risk for decay can change dramatically over time. Somebody in their 20s, 30s, and 40s might not have had a high risk of decay because they didn't have dry mouth. And then as they got older, they started to take the meds that caused their stomia, or they all of a sudden they started on a high sugar diet. We've met people that all of a sudden, got away with it for most of their life, and then all of a sudden, those Werther's candies that they were sucking on every day, 4 or 5 or 10 times a day, all of a sudden create a problem for them. Hygiene varies over a lifetime, but some people it's lousy right from the start. That is something to put into the formula of risk. And all of these things, as you go through them, I look at a smoker, and I already know, we all know that smokers have a magnitude of 2 or 3 times as much risk by my estimation relative to many of the dental diseases that we see. And also historically, have they had 5, 10 root canals over time? Did they have a whole bunch of restorations when they were adolescents and in their young adult that are now 30, 40 years old? And does all that dentistry, does it all age out on them? And that is risk factors. By the time somebody's in their 60s, 70s, or 80s, these teeth oftentimes are much higher risk than they used to be, just based on strength and fatigue. So all of those things matter relative to risk, and we do need to actually figure out, where does this patient, when I'm looking at them and when I'm talking to them, are they high risk? Are they low risk? Are they somewhere in between? Because deciding whether or not they're going to keep their teeth or replace their teeth is really going to be dependent on what do we think is going to happen in the future, and risk is important. So when we first meet a patient and we're talking to them and we're trying to get into their mindset, we want to determine how they're feeling about their dental health. We even ask them, what do you think your dental health? Do you think it's poor, fair, good, or excellent? Now, their perception of their dental health might not be accurate. We've seen it both ways. We've seen people who come in being extremely down on their perception of their dental health, and you look in their mouth and their teeth are fine. They might be discolored. They might have one bad tooth that's infected, that's giving them that feeling of unhealthy. But generally speaking, they're fine. There's also patients that come in and you look at the X-ray and you see multiple areas of infection, and that there's a lot going on and there's bone loss and whatever. And you ask them how their dental health is, and they think it's perfect. So be aware that asking the questions before you start to evaluate the radiographs is kind of important. And you want to ask them straight out, why are we here talking? What is your chief complaint? What problem am I supposed to solve for you? Because we've all seen patients who come in for a problem which is quite different than what you think it is when you look at the radiographs. So identifying their chief complaint is important, because you want to actually be somebody that solves their problems, not identifies a million other problems that they don't think they have. It is your job to let them know what their dental health is, of course. But we've all heard before that function, comfort, and aesthetics is what everybody complains about. But, you know, functionally, you know, how you eat, you know, is that a thing? You know, are you uncomfortable? Are you in pain? Are you self-conscious about your smile? These are all things that are variable from person to person based on, especially the aesthetics thing. You know, you could have somebody who has an absolutely horrible smile and they could care less. And you can have somebody, I met somebody today who was functioning on 2 or 3 teeth and they said they were functioning just fine. And one of the most interesting things is when you meet somebody and you ask them what their chief complaint is, why are we talking? And they say, oh, I don't have any complaints. It's really hard to treatment plan a patient comprehensively when nothing in the world is bothering them related to their teeth. So those are tough ones. So when we talk about these 3 complaints, it's really good to identify where they fall, what are they complaining about, and then we're going to come up with their solution after that. Previous to this new survey that we're having people do online, we've always used this new patient questionnaire. Nothing fancy, but you know, where in the mouth is the problem? Upper right, left, lower right, left, level of pain. You know, how do you feel about your aesthetics? What's your perception of dental health? Are you having trouble functioning? What's important to you that must be accomplished? These are all things, you know, upon completion of your treatment, what would you expect your smile to look like? What would you expect your function to look like? It's good to know all those things before you get into your treatment planning mode. The single most important question in dentistry, and I've been sharing this with many of my students over the years, all of the residents that I've trained over the years, all of the people who have done hybrids training. But this is the question that you're going to want to ask everybody when you're looking to start their dental treatment. You know, if we were to be looking back, you could say a year from now, or you can say upon completion of your treatment. But if we were to be looking back upon completion, and it doesn't matter what treatment you've decided to do, what are all of the things that treatment must have accomplished for you to be thrilled you did it? And that question is really important. So Mrs. Jones, you know, if we're all done with treatment, and it doesn't matter what treatment you do, but what has to have happened for you to give me the big kiss or the hug at the end of treatment that tells me that you're thrilled with the treatment that we did? Let's identify what success looks like for you. And you'd be surprised at what comes out when you ask them that question. What we're trying to do is we're trying to create value. And as we're treatment planning them and helping them make one of the most important decisions in their life, we really want to also show them and create value that we are here to guide them to not only the right decision, but the right outcome. I'm going to share with you a consultation that I did with this nice lady on the right here. She's here with her daughter. This is something that you know, I do about a day and a half to 2 days of consultations a week, and so I do this a lot, and I enjoy it. It's probably one of the best, most fulfilling things that I do. But I wanted to give you a sense for how I kind of pose these questions.
Like, we always want to know, like, what's the number one objective to treatment? And your answer was that you want a nice smile that restores your appearance and your confidence. Is that an accurate assessment?
I believe so. Thank you.
Okay. Where does function fall relative to that? Function being your ability to comfortably eat every day. Are you struggling with that right now?
No, not at all, because I have a plate, and of course it has wires, so I never have a problem.
Okay, so you really haven't missed a beat on the chewing at this point. That's not been your issue.
No, the only thing I can't do is like bite into an apple.
Okay. All right. You also rated highly having something that's healthy and dependable long term. Is that also accurate? That's important to you? Okay. And then lastly, you said that it's important that your teeth not be removable, like a partial. I'm assuming you were a partial right now.
For many years.
Is that, in your mind, has that been a negative to you? Are you trying to get away from something that comes in and out?
Yes, I think so. Although it's been comfortable all these years, but I think it's time for something permanent.
Okay, so you and I are talking today mainly to try to create maybe a better smile and something that is not a removable partial kind of an option. Is that accurate?
Yes. Yes.
Okay.
So prognosis-based treatment planning, evaluating the prognosis of all of the patient's teeth one at a time, really, and looking to see of the teeth that they have, how many of them are going to be here for the long term. And again, we're just trying to predict the course or the outcome. We oftentimes talk about prognosis as the 10-year prognosis. I would argue that on somebody who's 80 years old, the 10-year prognosis might be fine. When somebody's 40 or 50 years old, or even 30 years old, the 10-year prognosis probably isn't as relevant anymore. And you really need to talk in terms of over the next few decades, what is the prognosis, in order to not put a patient in a situation in 10 or 15 years or 20 years where they're starting from scratch. And I think looking further out is really important. So when looking at the teeth remaining in a dentition, we talked about all those factors that determine prognosis. And I think trying to predict that over time is important. One of the things that I'll typically do is I'll walk a patient through where their bone levels are, what the core strength of their teeth are. And in this case, for this woman, we're really talking about the maxilla here. That was her chief complaint. She's wearing that partial for the last so many years. I think she said even 40 years. And, she's now looking to do something that improves her smile and improves or eliminates the need to have to wear something removable. But in order to do that, we have to pick a path. Do we use these teeth? And you might look at that and go, oh, there's no way I'm going to use those teeth. That'd be silly. But we talk about occlusion too. Are the teeth, is the occlusion bad with the teeth they have? Is the position of the teeth bad? They super erupted? Are they flared? Are they? You might have teeth that have a decent prognosis relative to bone level and core strength, but the occlusion's lousy, or the teeth have moved so far out of their ideal position that you can't use them. So those teeth might also have a poor prognosis, but only because you can't restore them because of their position. Something to think about, and likely everybody has seen that. So we'll talk about Marie in a little bit more detail. As we look at Marie, and she's got those 5 teeth, and she's wearing a partial denture. It's actually pretty impressive. Whoever did her work 40 years ago did an awfully nice job, didn't they? When you look at this thing has really stood the test of time. A bunch of survey crowns and a removable partial denture. She's had good comfort and good function. You can't argue with that, really. This is just a couple of trio scans that I just threw in here for you, just so you can kind of see the lay of the land and kind of see what everything's looking like. I treatment plan using these screenshots, by the way, of an intraoral scan, because it gives me, when I'm treatment planning, it gives me the relationship of teeth to one another. It gives me the occlusion. It really allows me to envision the restorability of certain teeth. In the days prior to optical scans, what we used to do, and of course we were trained to always take study casts and mount them on an articulator and be able to look at that and spin it around and really evaluate occlusion and tooth position and all that stuff, and use that in our analysis of the treatment plan. But with the digital era, this has really been great, and I can show this to a patient, and it's very helpful from a patient education standpoint. So, when you look at this case for Marie, you might already be at where you are in what you look at. One of the first things that I'll do is I'll take them through and I'll educate them on their current status, because I might know what I think they should do, or I might have an idea when I look at those 6 teeth. I might already be judgmental on them and think negatively of them, but it's possible that the patient doesn't have the same perception that I do about their teeth, and therefore we have to get on the same page. I can't propose a treatment plan if they're under the impression that their teeth are perfectly fine and they've been using them for 40 years, and what's wrong with my teeth? And I think, well, I look at them and I think they're just full of problems. So the first thing that I would do in that situation is I would educate them from a dental standpoint. Let's judge their prognosis.
So this is your right and this is your left. And the first thing we look at is we look at bone levels. And that light blue line would represent the current bone level, and the dark blue line is where the bone level was maybe 30 years ago. So the bone level on these teeth is not that bad. These teeth are probably, none of them are perceived as being loose, correct?
Right.
Okay. When teeth lose their bone support, meaning not a lot of root in bone, they get wiggly. So I don't see really any of your teeth having that issue. For whatever it's worth, just because we're here today talking about it, if we were to do your lower teeth, they're also good. And I don't really see any issues with bone support on your lower teeth either. What are the teeth? And I'm gonna number them. This would be tooth number 2. Call this number 5, 11, 12, 14, 15.
So probably more information than that patient has ever had. We'll take you to the outlining of what I'm going to call the restore option, or sometimes I'll call it the conventional option. Again, remember, her objective is to have something that is not removable. She has 6 teeth, and clearly it's possible that a conventional implant option working around those 6 teeth is one of the options that we at least need to talk about and vet it out as, is it a good or a bad opportunity for her? So let me just take you through that conversation.
The path I was going down is, I know you don't want a partial, but if you said that you wanted a partial, I would say these teeth are going to be a crapshoot for the rest of your life. So the teeth that you have are, in my opinion, they're not all that dependable, which to me means that if we were to do implants, and let's just talk about replacing the teeth that are missing with implants, and let's say we said, well, you need 2 implants there, you need another 3 implants here, you need 1 here, you need 2 teeth here, and then you need so many teeth. If we were to just plug holes with dental implants and use the teeth that you have there and leave them there, that would be a very silly treatment plan, because it would be very expensive and it would keep teeth that you can't depend on in there. Okay, so I usually want to make that decision in my own head right out of the gate, that this, I'm going to call this a conventional option really is not a good option for you, because those teeth, numbers 2, 5, 11, 12, 14, 15, are not great teeth. Okay, so are we okay with that thinking? Which means that if you want to replace your teeth permanently, you know, with implants, let's say, that it's going to be a replacement that replaces all of the upper teeth, not just some of the upper teeth. Does that make sense, Marie?
Yes, and you could do that with implants?
Yeah.
All upper?
Yeah. Yeah, and that's why I want to be really careful about how we have this conversation, is because this is always where we start, and I need to let people know that there's a reason why we pick whatever path that we pick. The path.
So then typically, now we're looking at the other path, which is, we'll call it, if one of them is the restore option, we'll call it the replace option. And I want to go through it in a very systematic way and explain the rationale on this option as well.
Your upper jawbone, I'm going to outline it for you. It looks like this. And what you'll notice is that where the molars are in the back, that number 2 and 12, 14, 15, the bone gets very narrow back there. And so if we were to take out your upper teeth, because again, we're in agreement that these teeth are not for the future plan. And if we were to then look at, okay, where's the upper jaw really after you take those teeth out? What you're left with is what I call the good real estate. It's this area right here in the front. And that area is called the premaxilla. We're not going to test you on that. But the premaxilla is really, if you have good bone there, there's a really efficient, cost-effective way to replace your teeth just the way you want to. So this is a 12-tooth bridge. Again, it's a high bridge. It's a certain kind of a bridge, but it is all one piece. We sometimes refer to a high bridge as a full arch in the industry. And a full arch is like 12-tooth replacement. Usually we need anywhere from 5 to 6 implants. Some people put 4 in, by the way. They call that an all-on-4 concept. I personally like to put in at least 5, if not, if I can put in 6 implants to support 12 teeth. And the reason why it works is because implants in good bone are much stronger than a natural tooth. So we've been doing this sort of a restoration now for probably 20 years, and it works really well. But again, the bone matters.
And so now we've gone through both of those options, and let me just get rid of my optimizing here. So as we look at that, and you look at Marie's replace option, and you look at it and you say, all right, well, there are 6 weeks of treatment time and almost $21,000 of treatment cost if you add the cost of extractions and implants and the final prosthetic restoration. 4 appointments, we show them a very clear path of what is oftentimes has gotten to be a ridiculously simple path. When they are given this path, and we look at oftentimes the conventional path, there's no comparison relative to prognosis and time and cost and all that stuff. And that's really a point we're going to make in a couple of cases that we're going to look at today, is that, you know, as we look at Anita's case, so we'll look at case number 2 here. She is primarily focused on the lower, I believe, and I shall remember now, unfortunately, but here's her dentition, and here's her occlusion and their maxillomandibular relationship. And as we look at what we're going to evaluate, you know, where we could put implants in on the upper left, as I recall, actually just came back to me. We are going to put implants in the 3 and 5 position on the upper right, 12 and 14 on the upper left, and bilateral sinus augmentations, hybrid, or the implants on the lower as well. But this conventional path for Anita was $25,000, almost $26,000, 9 months. Again, bilateral sinus augmentation. Really not great teeth to begin with, but an awful lot of work and a lot of expense and a lot of time to do that. I gave it to her as an option because I thought it was a viable option. And then we look at option number 2, which is the replace option. And we go, instead of 26,000, we look at 21,000, 6 weeks in 4 appointments. And the fact also is that the bone is better in the premaxilla than it is in the sinus grafts anyway. So everything is pointing for this patient to replace their teeth. The only thing that would probably make any sense for Anita would be if she said, you know what, I've always thought there's nothing better than my natural teeth. I don't want to have a prosthetic. I don't want to have to clean underneath it. It means a lot to me to keep my teeth. Totally a great path then for Anita if she were to choose the restore option. On her lower, you know, we also looked at replacing the posterior teeth with implants. You know, implants on the lower left, 19 and 21. Implants on the right, number 27 and 29. 2 bridges, 4 months, 22, almost $23,000. And then option 2, the replace option, just remove those lower anterior teeth and do an implant supported restoration. Again, less expensive, faster, and frankly, more predictable in that the bone in the anterior is better than the bone in the posterior. So these are the conversations that we have every day. We'll talk about case number 3. This is Narlene. Narlene presents with her maxillary teeth. And as we look at those teeth, we need to pause and say, you know, are these teeth restorable, and do they have a good prognosis? And does the patient prefer to have a high bridge, or would she prefer to keep her teeth? The situation on the lower, by the way, is seemingly pretty clear. Let me just I'll walk you through this, but my conversation with Narlene, and I might have it in my next slide, but you know, as we look at the bone levels of the upper and the sinuses, we might say the prognosis of all of these teeth appear to be either excellent or at least good, except for, I would say, tooth number 4 and tooth number 13. Automatically, those 2 teeth, endodontically treated teeth, they're second-class citizens, in my opinion, and therefore, at best, they have a 10 or a 20-year prognosis that would be fair. But the rest of those teeth, if we were to restore them, I think would have a very good, if not an excellent prognosis, you know, worth considering. Now, obviously, if we were to want to replace tooth number 3 and put an implant in that area, it does add some additional cost. The lower, on the other hand, you know, there really isn't any bone in this posterior area. The canal is right below there. It would be really not a great probably option to try to put implants in the posterior. The bone is lousy, the soft tissue is lousy. replacing those lower anterior teeth makes a lot of sense to me, because what's underneath them in this symphyseal area is usually nothing but excellent bone and excellent soft tissue. So in a case like this, as we look at her occlusion, as we look at the condition of these teeth, we can try to figure out where we fall relative to restore or replace. And again, as we look at crowning 6 through 11, and looking at the lousy bone that we have in the posterior, probably we're going to go restore on the maxilla and replace on the mandible. And so if we restore on the maxilla, we know that that's half the cost of replacing those teeth. Makes perfect sense why we would want to keep those, as long as she doesn't want that tooth number 3, which she chose not to. And so this is a fairly, straightforward restore option on the maxilla. And on the mandible, really, there aren't any good fixed options with the quality of the bone in the posterior. We're going to sacrifice those lower anterior teeth. Most of them, by the way, had a great prognosis, but we can't figure out a way to utilize those teeth. And in fact, they're wasting good bone apical to them. So the replace option on the mandible becomes by far the better option, in my opinion. And we'll go into our case number 4. This is a kind of an interesting situation, I think, because Donald came into my office in 2019, and I didn't remember this conversation with Donald, but apparently I gave him the restore or replace option on the maxilla, and I'll show you what I ended up doing for him. So on the replace option, on the restore option, I recommended that he replace the posterior teeth with implants, I guess 3 through 5 and 13 and 14. And that would require, sinus augmentation. And I also recommended that he restore those anterior teeth and take off that anterior bridge and really shore things up. I didn't think this was his best option, by the way, because it turned out to be a fairly expensive path for him. And so when you look at that upper treatment, that restore option, and you look at extracting numbers 2, 14, 15, and bilateral sinus augmentation, 4 implants, the abutments and the bridge work, almost $24,000 over 9 months, 8 appointments, sort of a long drawn out process. That, by the way, is just for the posterior teeth. And, we talked a little bit about, future upper crown treatment on basically 6 through 12, like we talked about. And now you add on to that call it almost $10,000 plus the $24,000. We're up to $34,000. And at the end of the day, keep in mind that if we did this option, that he would have the anterior teeth would be probably would not have nearly the prognosis long term as any implant treatment would be. So if we compared the prognosis of this replace option and the cost, and we compared it to the replace option, not the restore option. So the replace option, we now have extract and graft the remaining upper teeth, 6 implants, a temporary high bridge put in the same day, never be without your teeth. You go 6 weeks, we'll put in the final restoration, $21,000, 4 predictable appointments. He had great bone in the premaxilla. We wouldn't have to do any bilateral sinus augmentation. Clearly, in my mind, no comparison. There's a $14,000 increased cost with option to restore, and you're still keeping teeth that don't have a great prognosis. And this is a 6-week, year 1 and done. Your inconvenience factor is low, and your predictability is high. For whatever reason, what Don decided to do is to do the conventional restore treatment. And so he decided to place the implants in the posterior. We did the sinus augmentation, put in some nice beefy implants. What we basically did is we committed him to a restore option forever. And I should keep that in mind. And this is something that when you look at cases that need 1 or 2 implants, and if we were just put a round number on 1 or 2 implants, even as, you know, $6,000–7,000 a tooth, it may seem like that 1 or 2 implants is less expensive than a full arch restoration or a full replace restoration. But once you put those 2 implants in, you're committing the patient indefinitely to replacing all future teeth that have problems with more implants, and typically 1 at a time. And so being transparent about that and really making sure that they know that, yes, you know, we can replace this tooth for right now, but understand that these other 4 teeth that are in your maxilla are problematic. And if they fail 1 tooth at a time, which they typically do, by the way, you're going to be paying $6,000 over and over and over again. And over the course of the next 20 years, you're going to hate us. You're not going to be very happy. And you need to make sure that you explain what that future is going to look like, because we've all seen it before. You know, we get sucked in, we get hooked into thinking that the conventional restore option is the way to go. But at the end of the day, we're living it with our patients as these teeth start to fail. So you really have to be good at predicting. So Donald actually came back, and I didn't remember Donald when I did his consultation a few weeks ago, and I looked at the case, and I could kind of tell that this was our type of implant restorations and the way this case was actually restored. And he came in with that anterior bridge broken off and decay underneath. I guess it would be number 11. That's kind of what he looks like in 2023. And unrestorable number said number 10 or 11, and number 8 was not very strong, kind of compromised. So as I'm looking at this, and I'm trying to figure out, okay, how do we, first of all, why did we do this case the way we did it? I could not quite figure out why I would ever have treatment planned around those anterior teeth. I didn't look at the case beforehand. And I kind of got in this sense of panic as I was looking at this. I'm like, holy God, this guy's going to go through a whole bunch more treatment. It's going to cost him now a whole bunch more. We're going to have to put in 3 more implants, and it's going to cost him another $20,000. And it's going to take us another 6 months, and he's going to be inconvenienced. And damn, why didn't we do high bridge? And even he asked the question. He goes, so what you're saying is I should have replaced all my teeth. And I thought maybe I hadn't given him the option, but I had given him the option. It was in the notes. And in fact, back in 2020, or actually 2019, I not only gave him this option of doing the implants in the posterior, but I also gave him the option of doing a high bridge. And that high bridge option, he chose not to do it. And so at least I had the out, and I did not say I told you so, by the way. But this was not a case. So even though he chose this path, I still feel a little bit guilty that I let him choose the path. You know, maybe I shouldn't feel guilty, but I kind of feel bad for the guy that it really was a very expensive decision for him. And we'll finish up with our 5th case. This is Samantha. This case is one of I wanted to finish on a case tonight that was definitely in the gray zone of, yeah, you could go one way or you could go another way. But I wanted to get you thinking about this a little bit. So with Samantha, you know, she presented with this situation where you know, she's got 7 through 12 in the maxilla, and she's got that number 15 back there. And she has what looks like pretty good bone pretty much everywhere. Recently lost some teeth. And, you know, as I started to ask the necessary questions about risk, I found out that she is a smoker. I found out that she has had a history of actually periodontal disease. She lost a bunch of these teeth recently because of decay issues. So she's had decay recently, which means that likely the environment in her mouth is high risk. And so her tooth loss, along with, you know, when we really look at this case and we say, you know, as we look at at least 7 through 11, 5 teeth, it really is hard to be too critical of those 5 teeth. You know, when you look at those teeth, you know, she's had them restored. She's got some veneers on them. And so as we look at the occlusion, we see the maxillomandibular relationship. This is what she looks like occlusally. And so as we do that, we say, all right, well, you know, let's just do the exercise. And we're going to take number 12 out because it's got issues. And we're going to do 2 implants, numbers 3 and number 6. By the way, the bone is excellent back there, so it wouldn't be a problem. And number 12 and 14, in that situation, I determined that we could take number 12 out and 1 stage the implant placement, and there's no sinus augmentation required. We could literally do these bilateral implant supported restorations around those 5 teeth and even leave number 15 in there. And we could probably feel pretty good about ourselves when we're done. The cost of doing that treatment, I called it the conventional implant path, where we are going to extract 12 and put our 4 implants in and do our 2 bridges. This case in my practice came out to be about $24,000 and would take approximately 4 or 5 months of treatment time, and 7 appointments. When I looked at the treatment sequence for this path, this is 7 appointments in our practice. By the way, we will always create a treatment sequence. It's a written document. No matter what we do, it's process driven, and we figure out every appointment. We put it in the document, we share it with the patient, and that patient then can follow along with our playbook as to how to get from the first appointment through to the 7th appointment, where they always know where they are at any step along the way. There's a lot of value to that within the practice, and there's a lot of value within a patient's mind that they know they know what's coming and they know how much longer they have to go. But anyway, in this situation, you know, many of you that are watching would probably say, well, this is a pretty good option. It's, you know, if you compare it to the replace option, you know, this is what I might do if I was, you know, a couple of things that I always try to tell patients is that, and I usually say, I always say I would never I would never trade my natural teeth for a high bridge or a full arch restoration. And they always kind of look a little shocked when I say that because they know I'm the high bridge guy. And I say, but I would trade your teeth for a high bridge. And they laugh a little bit typically, hopefully. But in that situation, what I'm really trying to get across is that I know I love my teeth. I wouldn't replace my teeth. And the chances are 20 years from now, I'm still going to have my teeth. And so there's great value in keeping my natural teeth. And they need to look at it the same way. But for Samantha in particular, we're really building this case around 5 teeth. And as you look back at these teeth and you realize that they're okay, they're not great. There's some recession there. You could even argue that there's a little bit of breakdown at the margin on number 11. Are these teeth going to last her 10 years? You know, I don't know, is she going to have an issue with any of these teeth in the next 10 years? You know, she's in her 50s. Are they going to last 15, 20 years? Those are the questions you have to at least pose, and you have to ask the patient, you know, if these teeth were to fail, you know, in 7 years or in 10 years or in 2 years, would you be disappointed that you ended up replacing the back teeth and now you have to replace the front teeth? And by the way, the front teeth are not going to fail all on the same day, are they? You know, maybe she bites into something in the veneer on number 7 breaks off and she snaps off the tooth, or number 11 gets decay and that becomes problematic. So, you know, what you have to keep in mind here is that you're committing this patient long-term to a conventional restore path, and that could be very expensive, as opposed to, let's take the teeth out, let's focus on the good bone. Let's really look at that premaxilla. Does it have good bone? And if it does, you know, can we same day, one stage, put implants in it? Can we immediately load the restoration onto those implants same day? And what's the success, or what's the inconvenience factor? What's the total cost? And what's the prognosis long term? Again, if you have these conversations with these patients, I think you let them choose the path with good information. I think the liability really falls away from you and puts it onto the patient, which in my opinion is, if you can do that, yeah, you're always better off. So anyway, I think that's pretty much where we're going to finish up tonight, and somehow on time. Feel free to reach out, and I always would be open and happy to know that you were paying attention at night here, and that you either enjoyed what we talked about, or you had questions about it, or even if you want to call me out and say you're crazy for taking those teeth out, feel free. But it's flamar@highbridgeimplants.com. So always enjoy it. You know, working with actually Catapult and trying to share some good information. So I'll stop sharing my screen, Lisa. I know Kim and Lisa are both on, and if there were any questions, I'm happy to answer a few here with a little bit of time we have remaining.
Dr. LaMar, one of the questions was, what options are there if the hybrid fails?
You know, I get that question a lot. You know, the fear, and it's not an unreasonable fear, but the fear is, oh my God, you take the teeth out, and you lose an implant, or you lose 3 implants, or God forbid you lose 6 implants, or you know, the hybrid fails, the restoration doesn't last forever, which we always build in the expectation that prosthetics have a certain shelf life. They don't last 30 years typically. I mean, maybe. We like to think they're going to last 30 years, but we don't build that expectation. But you know, if a patient were to have a complete catastrophe with their implants, then they can have more implants. There's nothing that says you can't remove implants, bone graft, and bring them back through treatment and redo it. That's obviously a horrible situation, but I find it to be a much less of a situation than the same thing happening on a natural dentition that we kind of banked on. But yeah, anything is possible, and I think that those conversations are important. Nothing is guaranteed forever, and we need to talk in terms of what's the likelihood that they get 10 or 15 or 20 years out of it.
Someone's wondering, what is the maintenance protocol for a hybrid?
We typically, first of all, we don't remove a full arch restoration like hybrid unless there's some sort of an indication, right? Either it needs some maintenance and we have to send it back to the shop, as we say, or if there's some concern underneath it and we want to remove it to look under the hood. But relative to normal maintenance, generally speaking, we start them off their very first appointment upon completion of treatment is we have them back 10 days later, and we show them how to take care of it, and we give them all the hygiene instructions that they need. Then we get them scheduled for 3 months after completion. And in fact, we actually take it out and we verify that all the implants are integrated after 3 months of healing time. And because we do an early load protocol, we'll always go back and just check things out. We'll also have an opportunity at 3 months to see if the patient has actually been able to access and clean properly. And if not, we modify the embrasures and create a better sort of cleansability. But once we get them past the 3 month follow-up, they're basically on either a 4 or a 6 month recall. Usually in the first month, we do two 4 month recalls. We keep an eye on them. We see how they're doing. We make sure they're good students and they're good hygiene. They're doing some good hygiene. And then we put them on, we say we're going to put you on a normal recall, which is every 6 months, just like a healthy patient. And we'll keep an eye on you long term with that. So that's sort of been our protocol for the last bunch of years. Seems to work out really well. Our hygienists do the maintenance with the patients. They get a chance to keep an eye on things and continue to modify their ability to clean properly. This is bridge work. This is fixed bridge. It's treated like a bridge. They have to be flossing and cleaning and irrigating, and that is a responsibility we're pretty transparent about with our patients. And we can modify, like we said, over time to make sure that they're doing a good job.